Professor Lee, would you kindly start your opening remarks?
Okay. Um, Good morning, everyone. Or good afternoon, or good evening, depending on where you are. I am Dr. Alex Lee from the Chinese University of Hong Kong, and my co-chair is Professor Kazuhiro Yamamoto from the Tottori University of Japan. Welcome to the APSC JCS 2020 webinar 10 session. The theme of this session is evolution of echocardiography in the management of heart failure collaboration with other specialties. Today we have four speakers from different countries around the world. I think this will be a very exciting session discussing the advance in echo in the field of heart failure. So without further ado, I would like to uh, ask, have Professor Yamamoto from the Division of Cardiovascular Medicine, Endocrinology and Metabolism of the Tottori University to introduce the session.
Okay. Thank you. Thank you, Professor Lee, and I deeply appreciate the organizing committee of APSC JCS 2020 webinar. I'd like to provide a short-time introduction of this session. This is my COI disclosure. This slide shows the trend in rates of each heart disease as a cause for the cardiac death in Japan. Over the past 20 years, the rate of heart failure has increased to be a leading cause of cardiac death in the current era. To prevent this increase, it is desirable to initiate the treatment at an earlier stage, and the diagnosis of heart failure holds the key. This is a list of causes of heart failure and consists of a variety of cardiac diseases, including the topics of this session. Because these are not only related with primary myocardial disease, but also secondary to other diseases, including cardiac and non-cardiac diseases. To prevent heart failure, the early diagnosis of cardiac dysfunction associated with these diseases are required. As shown in the diagnostic algorithm of heart failure guidelines, so echocardiography plays a key role in the diagnosis of heart failure. Therefore, the echocardiographer should be familiar with non-cardiac diseases as well as cardiac diseases. These points will be discussed in this session. This slide shows the progression of heart failure. In addition of the progression of the cardiac dysfunction, dysfunction of the other organs accelerates the development of heart failure, in particular the development of symptoms of heart failure. So ultrasound examination can assess the function of diaphragm as well as the heart as shown in the upper panel. So here, some patients with heart failure have preserved function of diaphragm as shown in the lower left panel. And the thickness of diaphragm of this patient can increase during inspiration. However, some patients have diaphragm dysfunction as shown in the lower right panel, and their diaphragms cannot get thicker during inspiration. We assess the effects of diaphragm dysfunction on exercise tolerance of heart failure patients. As shown here, among patients with sarcopenia or among patients with dyspnea but without sarcopenia, the diaphragm dysfunction was associated with shorter 6 minutes walk distance. Thus, in the management of heart failure, the assessment of function of other organs can lead to the deeper understanding of pathophysiology of each heart failure patient. So recently, theta intervention of structural heart diseases has been developing. During the procedure of mitral clip, transesophageal echo plays a key role as a navigator because mitral valve cannot see on X-ray fluoroscopy. Roles of echocardiography are not only diagnostic tool, but also the navigation tool. So conclusion, heart failure is based on cardiac dysfunction, and there are many causes for cardiac dysfunction. Pathophysiology of heart failure is determined by dysfunction of not only the heart, but also several other organs. The ultrasonographic assessment of the heart and other organs provide valuable information to fully understand the pathophysiology of each patient with heart failure and to find out the optimal therapeutic approach for each patient. Echocardiography is essential not only for the diagnosis of heart failure but also for the guidance of interventional therapy approach in patients with heart failure. Thus, currently, echocardiography is playing an important role with collaboration with the other specialties. Thank you for your attention.
Thank you, Professor Yamamoto, for your very nice introduction. So, heart failure is really a very important field, and echo plays an essential role in this disease. And we are going to see many advances in this technology, as introduced by Professor Yamamoto and the following speakers.
I'd like to move to the first speaker, Professor Lee from Chinese University of Hong Kong. His talk is heart failure related to pericardial disease. Professor Lee, please.
Thank you, Professor Yamamoto, for your kind introduction. I would like to thank the APSC and the JCS for giving me this opportunity to share with you on this topic about heart failure related to pericardial disease. And this is my disclosure. So I would like to share with you a few cases on pericardial disease, heart failure. So these are also some very memorable cases that I encountered during my practice in the past few years in patients with pericardial disease. This is case one. Is a 42-year-old man. He is morbidly obese, and he was recurrently hospitalized for right heart failure. And you can see from this picture, uh, he has gross ascites and also very severe bilateral leg edema up to the level of the thighs, and you can see the hyperpigmentation of the legs because of the chronic stasis of fluid in the dependent area. So he had very problematic clinical course, repeatedly admitted for right heart failure, requiring diuretics and also paracentesis, and also sometimes thoracocentesis for recurrent pleural effusion. Initially, he presented with fever, orthopnea, and ankle swelling, and also he also frequently has watery diarrhea. And another interesting biochemical features of this patient is that he has chronic hypoalbuminemia. You can see from this chart, he presented to us in more than 10 years ago in 2004 with his symptoms, and albumin is below normal and is dropped further to a trough as low as 17 gram per liter after 1 year of recurrent admission of heart failure without finding definite causes. And the 24-hour urine albumin level, however, was not high, so the protein loss is not from the kidney. And naturally, we ordered, or the primary physician taking care of this patient ordered an echocardiogram, and this is his echocardiogram. So this was done about 1 year after his recurrent presentation of heart failure symptoms. Someone finally gathered that they should get an echo for him, and then this is the echo, and this is the best image we can get. In this morbidly obese patient. The one who report the echo comment that this is a suboptimal echo image. I agree, but what I cannot agree is that he comment this is a normal LV function. I don't know how it can be confidently commented that this patient have a normal LV function or normal PASP, and he also commented there is a left atrial enlargement, but really this is the kind of image quality that we can get at that time. And because of this echo, seems that there seems to be commenting that this patient heart does not have any major problem. So he was, the patient was investigated extensively by gastroenterologist in the subsequent years. And these are the investigation that has been done on this patient. He has a liver biopsy for the ultrasound showing fatty liver, and therefore someone did a liver biopsy which shows again non-specific findings. He has multiple endoscopy, top and tail, to investigate for the possible protein losing enteropathy, because the urine protein was normal. So the GI people, while investigating for the ascites, was diagnosed him as having protein losing enteropathy. And he has an echo done once here in 2005, which unfortunately we didn't find anything, and with that poor echo images, and then not much investigation was done subsequently until 5 years after the initial presentation. Another physician ordered another echo for him because they're really suspecting something cardiac. And it is not surprising that when you look at the neck of this patient carefully, you will suspect this patient is having some cardiac problem. This is a very nice examples of a rapid X, Y descent of the JVP. And also when you see the height of the JVP, when the patient took an inspiration, the JVP height increase, and that's a Cosmo sign of inspiratory increase in the in the jugular venous pressure. And finally, we did another echo, and now we used contrast echo to this patient, and immediately you can see here the septum very clearly, and there is a very typical septal bouncing is revealed by this contrast echo with expiratory deviation of the septum towards the right side and inspiratory to the left side, classical for constrictive pericarditis. And this highlights the importance of clinical suspicions of constrictive pericarditis with the sign of JVP is something we as echocardiologists should also not to miss, and also highlight the importance of getting a diagnostic quality of echo, not to give up so early. And contrast echo is really useful in this particular case. And when we did the Doppler of the mitral inflow, you see this is not a particularly constrictive or restrictive type of mitral inflow, but there is some evidence of a respiratory variation in the mitral inflow with inspiratory decrease in the E wave. And then this is the tissue Doppler showing a hyper dynamic mitral annular diastolic velocity with a E prime of 11 centimeter per second. And then the hepatic vein showed expiratory hepatic vein diastolic reversal as shown in here. And there is plethoric IVC suggesting a severely elevated RA pressure. And all these together with the septal bouncing are quite diagnostic of constrictive pericarditis. Now, we we send the patients to have a CT scan, specifically looking at the thickness of the pericardium. And you see here is a thickening of the pericardium. And this kind of sign is sometimes called a Oreo cookie sign. And you see this pericardium thickening, white parts like the cream inside an Oreo cookie. And you can see the cookies biscuit, the dark side on the both sides of this thickened pericardium. So we send these patients with both hemodynamic and anatomic evidence of constrictive pericarditis to the surgeon, and pericardectomy was performed, and the surgical findings confirm thickening of the fibrous pericardium and marked improvement in the ventricular distension after resection of the pericardium. The surgeon even told me that when they cut open the pericardium, the RV popped out as like has been prisoned there inside the pericardial case for more than 10 years. And then these patients, after pericardectomy, symptomatically, his right heart failure resolved, and also his hypoalbuminemia also resolved, with the albumin gradually rising up back to normal over the subsequent few years because of the improvement of the protein losing enteropathy. So this is a very, I think is a memorable case for me, because this patient has been not receiving the diagnosis, proper diagnosis of constrictive pericarditis for almost 10 years. And yet still, after we can make the diagnosis by contrast echo, the patients still can recover and improve after the appropriate treatment. And this is a specimen of constrictive pericarditis with a fibrous pericardium thickening, and the etiology of constriction, many of them are idiopathic. Like in our case, it's also idiopathic, and the histology reveals just idiopathic fibrosis of the pericardium. There's no sign of tuberculosis or other specific pathological findings to explain. This patient does not have undergone cardiac surgery, but cardiac surgery is also a very important etiology of constrictive pericarditis, followed by radiation, acute pericarditis, and other. So it is actually quite well known, but we always forget, and it's time to remind us all that the presenting symptoms of constrictive pericarditis can be quite non-specific. Many of them just present with heart failure, more predominantly with a right heart failure picture. And many of them, because of the ascites and things, they underwent a lot of GI investigation, unnecessary GI investigation, including liver biopsy and all sorts of endoscopy, and it's quite well exemplified by our case. Management-wise, for patients presenting with acute transient pericarditis or transient constrictive pericarditis, if there's no calcification seen on CT or X-ray, a trial of medical treatment should always be considered before the more invasive high-risk pericardectomy. So recent studies has confirmed the efficacy of using either aspirin or NSAID in combination with colchicine to patients with acute or transient constrictive pericarditis. For those who are refractory to NSAIDs and colchicine, steroid can be used. But in many cases, like ours cases, with chronic constrictive pericarditis, medication is not going to work, and therefore pericardectomy is the only definitive treatment for this patient. Case number 2 is another interesting case that I actually encountered at the A&E. On one day I was on call as a cardiologist, and then the A&E officer called me saying that, hey, there is a 72-year-old man with stage 4 CA lung history, and come to us because of dizziness, and he's a bit hypotensive, but his blood pressure recovered after intravenous fluid resuscitation. And he said to me, he did an echo, a bedside POCUS echo. This is, you can see, this is a V-scan POCUS handheld echo. And he said to me that, hey, there is some pericardial effusion, not too much, and there is no cardiac tamina, I think you can come, as you find convenient. Uh, but when I went there and see this image, I know something's wrong. So what he called is a small amount of pericardial effusion is actually an extensive amount of pericardial effusion at the anterior aspect of the heart. And because of RV is indented to like a slit, so he didn't see this. He thought this pericardial effusion is part of the RV cavity, which obviously is wrong. So this four-chamber view show diastolic collapse of the RV and also the RA with large amount of circumferential pericardial effusion, and with, of course, the distended IVC and the subcostal view also demonstrating substantial amount of tamponade. So what we did, obviously, is to perform emergency pericardiocentesis. So this is an example of pericardiocentesis. We used echo guidance, and then we will find the entry site where there is maximal pericardial effusion, but a minimal um, chest wall or lung tissue uh, between the puncture site and the pericardium space. And then we usually do it like this. So we insert a needle, aspirate the fluid. So this patient has a very hemorrhagic pericardial effusion, probably related to the metastatic uh, status with underlying CA lung. And then we inserted the guide wire, and then we do a small skin incision after the guide wire is inserted, and then we perform agitated saline test to confirm that we are in the pericardial space, and then we put in the pigtail. So this is the echocardiogram before the pericardiocentesis, and after we insert the needle, we inject agitated saline, confirming that the saline is not in the heart, but in the pericardial space before we perform the aspiration of the pericardial fluid. And after pericardiocentesis, complete recovery of the tamponade and complete recovery of the RV collapse with hemodynamic improvement. So in terms of the management of pericardial effusion, in our institution, what we do is if there is a tamponade or large pericardial effusion that we think we need to drain it, then we will decide whether it is drainable. If it's not lockulated and it's accessible by a needle, then we'll perform, of course, urgent pericardiocentesis. If it's really lockulated and cannot be accessed percutaneously, then we will ask the surgeon to help for drainage. And we usually put in our pigtail catheter inside the pericardial space for over 24 hours as a prolonged drainage, because study has shown that prolonged drainage can reduce the frequency of effusion recurrence, especially in cases with malignant pericardial effusion or any other cause that prone to have a recurrent effusion. And if this patient does not have recurrence pericardial effusion, a few weeks we do an echo, and then we'll follow up this patient. If they develop recurrent pericardial effusion, then we'll consider asking our surgeon to perform a surgical pericardial window, or if the patient is not a surgical candidate, we perform percutaneous balloon pericardotomy. And this is an example of percutaneous pericardotomy that we did. We are doing a study of this technique. If you're interested, you can contact Dr. Tan of our institution by this email. So what we did is that we, very standard pericardotomy, after assessing the pericardial space, we inflate the balloon and then to create a pericardotomy window to allow drainage of the pericardial effusion outside of the pericardial sac. And this may avoid a surgical operation for pericardial window. I think I would like to stop here. And finally, I would like to make an advertisement for our meeting, Echo Asia, which is the scientific meeting of the Asian Pacific Association of Echocardiography. It initially was scheduled this year in May, but because of the COVID-19, we decided to postpone it to next year in May 28th to 30th. And we hope that would be a physical meeting, but with the COVID under control, or otherwise we may hold it as a hybrid or virtual meeting, and we will give more announcement later. But we do hope that you would register and participate in this meeting so that we can share more on this wonderful technique of advanced echocardiography. With that, I would like to conclude, and thank you very much for your kind attention.
Thank you very much, Professor Lee. And then I have a question. And in some patients with constrictive pericarditis, after the pericardiectomy, RV and RA is enlarged, and the severity of TR is also increased in some patients. So after the surgery, we have a problem about the control of the TR. So do you have any idea to predict uh, the severity of TR after pericardiectomy? So some patients maybe heart failure is controlled, but in such cases, right heart failure is worsened. So do you have any predictor before the surgery?
Okay. I myself don't encounter frequently this problem of worsening of TR after pericardectomy.
Mm.
I really cannot tell what we can do to that. What do you think is the mechanism of TR increase after pericardectomy? Is there any pre-existing TR in some of these patients?
Uh, so in patients before the surgery, there's a TR, but after the surgery, maybe after the release from the constriction, RV is sort of enlarged.
Ah,
So
so
the
maybe
TR is worsened. Yeah.
so maybe there is some RV problem after releasing the constriction. So the RV is allowed to
Yes.
dilate
Yes. Yes. Yes.
freely, and
Yes.
then okay. So because in my experience, if the RV or the tricuspid valve is normal to begin with, just releasing the pericardial, just doing a pericardectomy will not cause TR. That's my own experience or my own belief. But if this patient have some pre-existing right side problem that
Mm,
can cause that is already a TR is masked
mm,
by the constriction, that I think that could be a case. So I think we don't have good means to predict it. I think apart from standard imaging of the tricuspid valve to see if there's any organic or disease of the valve. Other than that, we really can't predict it. But we have to treat it. If there is worsening of TR after the surgery, intraoperatively, maybe if they can detect it, they probably should do a tricuspid annuloplasty at the same session. Otherwise, if it's after operation, then we have to treat it with diuretics, or sometimes now we have percutaneous treatment for the tricuspid valve with, for example, mitral clip that sometimes we do for our TR patients. I think that's we just follow the standard pathway to treating those
okay.
patients.
There's a question from the audience. If prior to surgery TR is severe, do you recommend to tricuspid valve annuloplasty during the surgery or not?
Oh, okay. Yeah, just as I just said, if the TR is severe before or during the surgery, then the surgeon would do the tricuspid annuloplasty.
Mm. Okay. Thank you very much, Professor Lee. I'd like to move to the last speaker, Professor Sakata from Osaka University. His topic is heart failure requiring implantable LVAD. Professor Sakata, please.
Thank you, Chairpersons. I'm Yasushi Sakata from Osaka University. I'm really appreciate the JCC, JCS, and APSC to give me the opportunity of my presentation. So today's my topic is heart failure requiring implantable left ventricular assist device. Okay, I have some COIs. So left ventricular assist device is a very important tool for the bridge to the transplantation, particularly in Japan, because Japan has a very long waiting time. So now we can use 3 types of left ventricular assist device: LVAD, HVAD, HeartMate3, and EVHeart2. And most patients who are waiting for a heart transplantation are implanted left ventricular assist device. So echocardiography has a pivotal role in the examination of a patient with LVAD implantation. So before operation, we need a patient selection, and during the operation, we have to check up using the TEE imaging. And after operation, well, we are doing a post-operative surveillance, optimization of LVAD function, and we have to examine some problems. And after that, we need to evaluate the native myocardial recovery. I'd like to show some examples in the number 3 and number 6. So this is a patient of 29 years old male. As you can see here, this is a thrombus attached to the inflow cannula. So this is a critical complication, and of course it disturbs the inflow, and this may cause the brain embolism. So we need some intervention, including the exchange of this device. This is another critical complication. So she has a dilated cardiomyopathy, but before operation, she had no aortic regurgitation. But after 1 month after implantation, she has some mild to moderate aortic regurgitation. And then 4 months after implantation, she has very severe, like this, severe aortic regurgitation. But this aortic regurgitation make a blind loop in that native heart and the LVAD. That's a critical situation because she has a low output. So of course she had signs of heart failure. So she required the closing of aortic valves. But fortunately, she had a heart transplantation. Now she is very well. Okay. And another situation, we need to examine the heart function even after the LVAD implantation. So he had a very dilated heart and a very low ejection fraction. But 6 months after, and even 21 months after implantation, he had still had an enlarged heart and very, very low ejection fraction. And he showed some heart failure symptoms. So he required continuous inotrope infusion in the hospital. But fortunately, he had a heart transplantation, and now he is very well. But okay, some patient has a recovery like this. So he has also dilated cardiomyopathy, and 1 month after implantation, it's almost same. But 7 months after implantation, he showed a good recovery of the heart. And unfortunately, he had a complication of severe infection. So we need to remove the left ventricular assist device. But fortunately, he keeps the recovery of the heart. Now he is very well, and right now he don't need heart transplantation. So he's very lucky. Okay, so during and after operation of LVAD implantation, as I said, echo has a very pivotal role in the surveillance or something. However, the echo still have a challenging role in the preoperative patient selection because this is a prediction of the future. So it is a still challenging role. So, in the preoperative patient selection, the echo has some roles. The first is LV evaluation of LV dysfunction, of course, and the second is RV dysfunction. Then, as I said before, we have to check the aortic regurgitation, or particularly tricapsid regurgitation, because it's need to modify during the operation. And if the patient has a small ASD or PFO, we need to close during the operation and as high-risk finding. So now the most challenging topic is RV dysfunction. So RV failure is not rare phenomenon in the Japanese patient with implantable LVAD. So definition of RV failure is need for right ventricle assist device, LVAD, or extended inotropic support for more than 14 days. This is a JMAX data, Japanese data. So this is a non-incidence rate. That means after one year after the implantation, so 7% of the patient shows a RV failure. It's not very rare. And RV failure causes poor prognosis in patients with an implantable left ventricular assist device. So this is a little old data, but the patient with LVAD and RV failure has a very low survival probability, and particularly this LVAD. So LVAD, if the patient has an LVAD and LVAD, it's called BIVAD. And BIVAD patient has a very low survival rate, particularly within the 6 months. And after that, it's decreasing like this. So we need to evaluate the RV dysfunction before the operation. And if we can intervene something, we need that. So echo has some tools to evaluate the right ventricular function. So this is a 3D echo assessment. This is a 2D RV fractional changes. And this is a tricapsid, so-called TAPSI. This is 1D. We have 3D, 2D, 1D evaluation of a systolic function. And in addition to these B mode, M mode study, we have tissue Doppler imaging and even strain imaging in the LV free wall. However, the APSC recommendation says the literature does not support the use of any single echocardiographic RV parameter for predicting the post-LVAD prognosis or need for BIVAD. So, and in addition, APSC recommendation also says quantitative echocardiographic parameters of RV function should be integrated with clinical signs and symptoms to determine the degree of preoperative RV dysfunction. So they say, so we have to integrate the signs and symptoms. Why is that? So this is my hypothesis. So these parameters are 3D RV, EF, FAC, TAPSI, STV, and strain imaging mainly evaluate the RV systolic function. Of course, RV has another function, RV diastolic function, so we need to evaluate RV diastolic function too. But as you know, this is very difficult to evaluate RV diastolic, even RV diastolic function. So we need to find the alternative of RV diastolic function, and the best, we think, that very feasible and the best alternative is right atrial pressure, because if when the RV diastolic function is deteriorated, RAP will be elevated. However, as you know, RAP is influenced by many factors like preload, fluid retention, or afterload, PVR or something, and even external factors like compression from left ventricle. So these are temporal. These are external factors. So this RAP is influenced, but these are temporal factors. So if the patient has a very severe right ventricular dysfunction, so RAP will be elevated for a long time. So it influences some clinical symptoms and signs. So Dr. Lee said in the pericarditis, so he said some patients show the liver dysfunction, or some patient has a very severe edema. So something like that. So what's the best, what's the focus point? What's the best focus point of clinical symptoms and signs? So we focus on the congestion of the liver. So this is the patient of 30 years old male. He is an end-stage HCM. So he had a dilated heart and large RVD and low LV ejection fraction and high wedge, and also he had a very high right atrial pressure. So unfortunately, we lost him. And in his histology, his liver is a very large. It's called nutmeg liver. And in his histology shows atrophy of dislodgement of the hepatic cells and even fibrosis around the hepatic cells and the veins. So I think this liver is enlarged, and also this liver is very stiffening. So we can focus on these signs, and we think we can combine these data. So we can use, we are interested in the liver elastography. So this device sends the shear wave into the liver, and we can follow the velocity using the Doppler signals. And then we can find that stiffness, liver stiffness, using these figures. So shortly speaking, I'm sorry, we have a limitation of time, but shortly speaking, we found the liver stiffness is closely related to the RAP, and that liver stiffness shows a closely related to liver fibrosis. This is a data of collagen type 4 in his patient plasma, and compared to the low data of liver stiffness, the high data of liver stiffness patient shows a high concentrate of collagen type 4. That means that he may have a severe liver fibrosis, more severe liver fibrosis than the patient with low liver stiffness. So then we found that this liver stiffness can predict the cardiac event. This is not a heart LVAD patient, but these parameters, liver stiffness parameters, can predict the cardiac event in the heart failure patient. That means this liver stiffness may indicate the high right atrial pressure and long-term right atrial pressure. And this is the data from our surgeons, and it shows the patient who required right ventricular assist device has a higher liver stiffness data than those without LVAD. and this data also support the data. So we think, so we can, of course, we can examine the right ventricular systolic function using these parameters, and also we can evaluate the right atrial pressure, but that we need some clinical symptoms of sign, including something. So we can combine these echo data and these parameter of liver stiffness may be able to predict the RV failure. And I think we need I think the patient need a left ventricular assist device before the severe RV dysfunction. So that's a very important point that we can decide the timing of the implantation of left ventricular assist device. So this is my conclusion. Echocardiography is a key method to manage patients with LVAD implantation. However, prediction of RV failure is still one of the challenging issues in optimal patient selection of LVAD implantation. So no single parameter of RV function predicts the post-LVAD prognosis or need for the biventricular support. So we need integration of echo data into the symptoms and signs. And this is our hypothesis. Liver stiffness is a good alternative of symptoms and signs, and the liver stiffness may be a promising parameter to predict RV failure in left ventricular assist device implantation. Thank you for your attention.
Professor Sakata, thank you very much for your presentations. May I have a question? And as you shown in your slide, the elevation of right atrial pressure is partly due to the RV dysfunction, but also partly due to the compression from the left ventricles. So in the latter cases, if the LVAD is implanted, then LV is unloaded, maybe RAP is decreased. So is there any method to discriminate the reason for the elevation of the atrial pressure before the LVAD implantation?
Thank you very much. So that's a very important question. So I think we can distinguish we can see the preload, like afterload, preload fluid retention. So that's I think it's not very difficult. But as you said, the compression, the effect of compression is very difficult to find. So that's a also challenging issue. And if we have a good parameter to evaluate the compression, I think we can combine in this situation.
Okay, thank you very much. Now, almost all the time is spent, so we would like to close these sessions. I would like to thank to the Professor Lee, Professor Negishi, Professor Liang, and Professor Sakata, and also the all of the audience. Thank you very much for participating in this session. Thank you very much. I'd like to close this session.
Thank you very much.